Thank you for joining us today, everybody. Today's webinar, A Game-Changing Approach to Reducing Falls. I'm Carol Longman, the Director of Sales at West at Her USA. A little bit about her, if you aren't familiar, we've been in business worldwide for over 35 years, and we offer ergonomic software-enabled pneumatic strength training and balance solutions. And with her, no one's excluded. Athletes, seniors, wheelchair users, and rehabilitation patients all benefit from our design and technology. So today I'd like to take a brief moment before we begin to introduce our presenter. Dr. Jenny Hewitt is a clinician, researcher, and educator with a focus on aged care and physiotherapy. She's received the Australian National Lifetime Achievement Award and the Morley Award for her impactful research. Dr. Hewitt advises national health bodies on senior exercise programs and leads research on positive aging, while also teaching at the University of Sydney. If you have any questions as we move through today's webinar, please type them in the questions or chat section on our Zoom call, and it's in your toolbar. And then all your questions will be answered at the end, and I'll moderate that. So I'm going to hand it over to Dr. Hewitt. Take it away.
Hello, everybody. I was tempted to say good morning. It still blows my mind that I'm across the date line and below the equator. So for me, it is Friday morning and it's very hot because it's the beginning of summer. Welcome. It's a real pleasure to talk to you. It is a great area of passion for me, helping the oldest old get back on their feet and achieve their dreams and goals. So I'll just start by sharing my slides. Carol, just let me know if you can't see the slides. It's indicating to me that you can. So we're going to talk today about exercise, restoration or reablement, some new balance games, and I'll just touch on cost effectiveness of exercise programs for seniors. This is not file footage you're seeing here. It's a genuine photo of some of my participants in my trial. You may have heard of Byron Bay. It's on the east coast of Australia and a very popular tourist destination. We have a small care home in that area that was turning 25 years old. And we gave the residents a list of options for the 25th celebrations of the care home. That included things like a party where you could have your friends and family, a high tea, a few other options, and going out to restaurants, etc. And the bottom one, which we thought was a bit of a joke, was a ride on a Harley Davidson, and they voted for the ride on the Harley Davidson. So I like to include this photo because it shows that it doesn't matter if you're old and frail and living in a care home, you still want to have fun and have the capacity to do some interesting things that are out of the box if you can be supported to do so. Okay, let's make a start. So I put a few learning objectives in here in case some of you may be able to use this for continuing professional development points. I will talk about evidence for falls prevention and functional restoration, which means being able to get back to things that free you up to conduct life and participate in the things you want to participate in, physical reablement, and they're all possible in long-term care and for old, frail people still living in the community as well. If you're supported with the correct dose of strength and balance exercise as the basis of your treatment plan, as well as addressing other comorbid conditions. So we're going to talk about the key principles of what best practice exercise looks like so that you can scale and implement this program in the real world. So I focused on falls in my research, mainly because quality of life is actually my personal primary driver. I love to see older people with an ambition or a wish to do something and then work with them towards achieving it. But I really wanted to be able to use the research to advocate for policy change here in Australia. The government, our system, the government does fund programs, reablement programs for older people, but once they moved into long-term care, they actually removed any funding for or support for any kind of exercise program, and I felt that was a real injustice. And so I used falls as my primary outcome for the research we're about to talk about, because falls cost the government a lot of money. And as much as we like to be, they have that soft, cozy feeling that they'll like the nice stories we talk about getting people back on their feet, they actually need to see dollar figure as well. So that was why I focused on falls. But falls are a huge problem worldwide. The World Health Organization is focusing on falls as one of the key priorities of attention. And that first statistic comes from them. So 684,000 people around the world dying as a result of fall. But look how many people are left with short and long-term disabilities. About a third of people who live in their own homes or out in the community will fall every year if they're over 65 years of age, and that is roundabout doubled if they live in long-term care. Falls in the long-term care setting are the leading cause of preventable deaths, and this is an Australian statistic, but no other injury, including motor vehicle accidents, cost the health economy more than falls do. So I think you call us physical therapists in the USA. In Australia, we're called physiotherapists. So as a physio, I felt like back when I started looking at this, I felt like if I just get everybody on strength and balance program, I'll smash the falls, they'll be gone, and we'll all live happily ever after. Of course, falls are not just strength and balance issues. So what I'm talking about today focuses on remediating the strength and balance issues, but falls are multifactorial. So we need to look, if we're going to do a thorough analysis of how to prevent a fall for a person in front of us, it's important that we look at the other key risk factors and see if they also need some attention. I didn't do that in the study that I'm about to present to you. We did focus just on strength and balance. So if somebody, for example, has arrhythmia and they need a new pacemaker, they still need a new pacemaker. My strength and balance program isn't going to cure it. Or if they have a visual impairment, then we might want to help them, with better lighting and reducing clutter and those sorts of things. However, what does happen if you focus on strength and balance exercise is that even if they have those other factors that are contributing to their falls risk, if they're able to quickly react and catch themselves in the event of a fall, we can reduce their risk of falling, even if they have those other comorbid conditions. Now, don't be frightened off or let your eyes glaze over at this slide. Back when I started looking into this, it was around 2011. And I thought at the time I would probably just be able to find good quality evidence out there in the research that exercise does prevent falls and improve mobility in residents of long-term care. And so I started looking through Cochrane reviews, systematic reviews, that sort of gold standard level 1 research where other people have brought together all the known studies and had a good look at what works and what doesn't work. And what I discovered is that for exercise programs in community dwellers, so people living outside of long-term care, even if they're in retirement villages, they're all included in this, just people who are not, I think you call we're focusing on skilled nursing facilities as your sort of similar level as what I'm referring to here. There was hardly any research for people living in that kind of level of care. There were 600 studies at the time for people living outside of that long-term care, and only 9 studies for people living in long-term care. And these people had exercise programs. So this is the small group that could be bunched together, the small group of research papers. And the little red squares indicate if it falls on this side of the vertical line, it indicates that the doing nothing was actually got a better result than this particular exercise program. People fell more often doing this type of program than if they didn't do the program. The same for this one. This one was a little better, but that black line indicates that there was a range of outcomes. This one was really the only one that was entirely positive. This one was very negative. So in other words, if you did that exercise program, you were a lot worse off. So this was really distressing for me back at the time, and I'm sure it's distressing, and we all scratch your head. You go, we know exercise helps, so why is that what we've found? And this diamond at the bottom indicates that the mathematicians have put all this together and come up with a pooled result from all that data, which falls right on this line that says we don't know if exercise works or not. Well, I had a bit of a light bulb moment at the time and thinking, exercise is like medicine. I'm an exercise scientist, a physiotherapist, an exercise, all of you who are exercise professionals, we know one type of exercise is not the same as the next type of exercise. We should be thinking about dose, the type, and how often. So I like to think of it, if you consider a diabetic, for example, coming to see their medical practitioner, if the medical practitioner prescribed them paracetamol, let's say, for their blood sugar levels, it's the wrong type of medication. So they will take that and there will be no change and no improvement. If the medical practitioner prescribes insulin, but at a half dose, then that's also not going to improve their blood sugar levels. If the medical practitioner prescribes insulin at the correct dose but tells them to take it every Monday and the other 6 days, it's not enough. And so in the same way, the type of exercise, the dose of exercise and how often we do it is important. And what if all those studies were doing the wrong type of exercise? So that's what I looked into. This is a busy slide, but it's important because at the time, you can see this is back in around 2011 and it's been updated in 2017. These studies, Professor Sherrington and Tiedemann, they pulled together all of the exercise programs that had been looking at falls for people living in the community as well. And they came up with key components like a recipe for what is required if you want to prevent falls. So the total dose of exercise needed to be about 2 hours a week over 6 months, roundabout. They needed to have high-level balance work and strength work if people were deconditioned. All of the exercises needed to be individually prescribed, so a one-size-fits-all doesn't work, and they need to be upgraded or progressed as a person improves across that 6-month period. And closely supervised so that you don't ask people who are high falls risk to do, to stand on one leg or do the Macarena and in a big group and then they all fall over. After the 6 months, you need to continue with a maintenance program. It's just the same as for the rest of us. If you go gung-ho on an exercise program and really make improvements, but then you stop, then you'll start to, those improvements will start to reverse. And a walking program, interestingly, while it's beneficial for so many health conditions, should not be considered a falls prevention program. So luckily for me, they published this just around the time I was trying to design an exercise program to prevent falls in the long-term care setting or for people living in their community who are highly deconditioned or weakened and disabled. So when I mapped that prescription back against these exercises studies we had looked at a few slides ago, not one of them implemented that type of exercise. In fact, this one over here, the outlier, was a walking program. So what that showed us is that just asking people, older people, to get up and walk is not going to help prevent their falls, especially if they've been sitting for long periods of time. So what we really need to do is focus on getting them strong enough that they can catch themselves should they start to tip over, both their upper bodies and their lower bodies, but also improve their reaction speed so that if they start to lose their balance, they can shoot a foot or a hand out quickly. And so a walking program is still encouraged for older people, but it doesn't count in those minutes, those essential minutes required as a prescription for falls prevention. Now, apologies if this looks a bit busy too, but what I wanted you to see here was that I recruited 16 care homes or skilled nursing facilities. We had 221 beautiful participants put up their hands to say they would participate in a clinical trial. And, their mean age was around 86. The oldest was 101. We had people, there was a lot more women than men, and sorry guys, but that's because there are more women living in long-term care, at least in Australia, but I suspect because of the longer life expectancy and sometimes less people at home to care for them if they find themselves alone. They had been, I have highlighted the falls there because you can see the people that were randomized into the intervention or the exercise group had 189 falls in the prior year, and the usual care group had only had 114. So we randomized according to the level of care they needed. So how many falls they'd had was basically not accounted for in that. So if I was a betting woman, I'd have been, well, I actually was really nervous when I saw this, because I thought we have the worst falling group here in the intervention group. And so if you've had one fall, you're at risk of further falls. I was worried that this may skew the results at the end. It turned out to be not a statistically significant difference. But you can see there they have anxiety, depression, arthritis, cardiac disease, cognitive impairment, gait or balance disorders, hypertension, osteoporosis, musculoskeletal pain, visual impairment. So all of these risk factors for falls, they had them too. So we're not talking about a group of young, fit, well, older people. We're talking about a pretty good snapshot of the type of people with a whole lot of complex health needs that tend to live in these types of homes. I had prescribed vitamin D down there. You can see there's only about a third of them were prescribed vitamin D in both groups. That's because at the time we started this study, which was 2012, the only thing that we could see in the literature that did seem to reduce falls was a vitamin D prescription. So nowadays, the World Guidelines says that unless it's contraindicated for an individual, people should be on vitamin D. They think that the vitamin D it reduces the impact of falls because it helps bone health, so fractures are less, but it actually seems to reduce falls as well. And the thinking around that is that it's likely associated with reaction speed. That's sort of for another discussion. So what did we do? We included progressive resistance or strength training and high challenge balance, basically implemented what was in that key recipe. We did 2 hours a week for 6 months. All the exercises were individually prescribed. And what we did was had our residents come for an initial session with a physiotherapist to prescribe the correct dose. So a weight or resistance that was going to mean that the person felt that they were moderate. It was moderate to hard after they'd done a set of about 10 repetitions. So if we, for example, you see this fellow, one of my all-time favourites at the top, he looked so cool with his dark glasses. He wore them because he is like photosensitive. But I do love, and the lady at the bottom, a lot of them would come to the gym wearing their dark glasses and looking hot, like rock stars. Anyway, so the fellow at the top there on the adduction machine, we would get him to push out into abduction, and we would get him take an estimate, for example, of 6 kilogram resistance on both sides and get him to push against it, and then hold up that chart you can see at the bottom, the Borg scale of perceived exertion, and ask him, was that light, hard, very hard? And he'd say, well, it's a bit hard. So then you can show him it falls in the green area, somewhere between 12 and 16 on a scale of 20, for example, or green if they prefer colour, or somewhat hard to hard if they prefer language than numbers. And then we'd know we'd got the correct resistance. And then we did that through each of the resistance training devices. And then we introduced high challenge balance work as well. I'll talk a little more about that in a moment. This is a video to show you what it looked like. I'll just turn one moment, please. There we go. I have loud sound coming out, which I know you do not. So you can see we had up to 10 people in a class. We had a circuit set up. I'll talk through the types of equipment we used. You can see leg press here. Each person, I'll pause here. This is one of the things I loved most about being able to prescribe using this equipment. I was very fortunate in that her Australia and her International provided 5 pieces of resistance training equipment. And what that meant is that we could individually prescribe for each person. I'll let the video run forward a little. There. Oh, sorry. You can see a small screen here on each piece of equipment and a card, which was actually been modernized since then. But we were able to set the correct dose for each of these pieces of equipment, and this meaning the correct weight, the correct number of repetitions, and the correct number of sets. Pop the card in, it pops up and saying hello with her name, which I have permission to share. And each time she'd done a set of 10, let's say, it goes beep. So even though she's visually impaired, she knows she needs to stop. And so I had a trained volunteer, the lady on the right in the floral shirt, to help people move from one piece of equipment to the next. And then I could work individually performing, or the other physios, in a high challenge balance, dynamic balance. Then we got them in a group around the table. These are heel raisers and toe raisers. I do have a list of the equipment for you here coming up. But they were in a group doing some of the balance exercises. This is static balance. So this fellow has his eyes closed, his feet together. Some of them have one hand on the table. Some of them have no hands on the table. They're either standing with their feet apart together, semi-tandem or tandem. These ones are reaching outside their base of support. So reaching, I want you to take note of their faces for later. You see, they're not exactly looking like they're ready to party. And I'm going to talk to you about that later. So reaching out of their base of support, because people tend to fall when they reach for things. This is practicing catching yourself. Not for the faint-hearted. Falling, falling, catch, falling, falling, catch. So specifically learning to step in different directions. Look at the lady in the yellow, falling, falling, catch. This is high challenge balance. You have to be strategic so that you don't lose people falling over in your class, and have something in front, something behind, and stand your volunteer or your trained therapy assistant or yourself between the people most likely to fall, so that they can still take a risk and practice this. And that work was done in all directions, forward, backwards, sideways. But this is how we did it in the Sunbeam research trial. The results were published in the Journal of the American Medical Directors Association back in January of 2018. But the most exciting part was that the falls rate after 12 months was 55% reduced in the people that participated in the exercise program. So this was a game changer, because up till then, you saw those slides, that slide that showed you the outcomes people were having from exercise programs, but none of them had implemented this kind of specific therapeutic dosage of exercise, and that's what we did here. So that, for those of you who are interested in statistics, the 55% comes from this, so 100 minus 45 is 55, and the confidence intervals, that means we are 95% sure, because these numbers do not cross the number 1. We are 95% convinced that it is the exercise program that made the difference, not other things. So that is a really strong statistical finding, and why JAMDA decided to publish. Other outcomes were the fall rate. You can see that the fall rate in the intervention group was 1.3 falls per person, and it was up to 3 falls, 2.9 in the usual care group. The total number of falls was dramatically different. The people that fell was markedly less. And you may recall from that first slide I showed you, there were more fallers in the intervention group at the baseline before this than there were here. So people who fell prior to the exercise didn't fall again. We start getting a bit small here to do any statistical analysis, but it's encouraging that the repeat fallers was a lot less as well. This was statistically differentiated statistically. So what we found here was that the injurious falls meant pain, bruising, skin tears, fractures. So any of those things, you can see there was a statistically significant improvement in the intervention group, and less people going to hospital, less ambulance requirements, not much difference in the fractures, but some of these fractures were toes as opposed to hips. So I love putting this slide in of this lady. She was 101, and she was a retired nurse who felt strongly that there wasn't enough exercise in skilled nursing facilities, and she participated in the trial, and her attendance was stellar. So out of the 50 sessions, she attended something like 45 sessions, which is amazing when you consider how often older people get sick, or maybe the visitors came, or maybe there's a bus trip for Christmas shopping. You've got all these other things you compete with in this setting. I really enjoyed the fact that people also told me that their pain was improving. We didn't measure pain as an outcome, but it's important because a lot of people think they shouldn't exercise if they're old and they have pain. I'm going to talk a little more on that later as well. That lady that said, I have much more get up and go now, she had told me previously that my get up and go got up and went. So when she said she had it back, I was really pleased. And people, the families were thrilled as well as the staff. You know, it hurts to see people that you love and care for have an injurious fall or lose their confidence because they keep falling. So this was a really positive addition. And seeing the pride in the faces of people telling their family members that they were going to the gym. I can't talk now. Love, I'm off to the gym. Family members would come in to see their parents or grandma in the gym. It was really a very positive addition to their life, their routine. So what equipment did we use? We had her leg extension and curl, which did knee extension and knee flexion, one machine that does both. The same for abdomen and back. We had adduction and abduction, so that's also one piece of equipment for both. The dip shrug, we just used the dip part, so that's tricep dip, and we chose that one mainly because people have trouble getting out of low chairs or out of cars when they want to stand up, and the leg press for strengthening. So it was predominantly leg work, and that's kind of obvious, I guess, but we did want to include some trunk and upper limb exercise as well. I really do think, and I have no commercial interest in saying this, but I've been doing this now for over a decade, and I have been a physical therapist for 34 years. And so I've used lots of different types of equipment, but I can say that access, so getting on and off this equipment, is just so much easier with this set. So I have used other sets, and I even sometimes now I go to gyms where there are other sets that have been built for people that are younger and fitter, and they're harder to get on and off. And also they have some edges on them that end up with a small bump equals a skin tear in people that are really old and frail sometimes. So I have more, there were no adverse events in this study in terms of those sorts of issues. There was one fall, non-injurious fall as well, which was not associated with the strength training. And the lady got herself back up again and dusted off and got back into her exercise program. So that was a relief. So the other thing is that this exercise equipment is, it uses pneumatic pressure, so air pressure being pumped with a compression pump through pipes. So you don't have a whole lot of weight stacks that are going clang, clang, clang. But also, I could put somebody on a dose this week of, let's say, 11 kilograms for their leg press. And if they found next week it seemed a little easier, I could put it on 11.5 kilograms, or I could put it on 11.25 if it was triceps. I could progress it in teensy-weensy increments and bring it back into, or I could jump up 3 kilos and that's too much, so I could go 1.5 kilos, very easily adjusting with that digital setup and the amount of pressure that it's pumped through the pipes. And that's a bit harder when you have weight stacks and you only have options of, say, 1 kilo or 3 kilo or 5 kilo, depending on what you're using. The high challenge balance exercises we used were standing. You saw the people doing the heel and toe raises. So they had the table in front and the chair behind. They go up on their tippy toes, back on their heels, and they'd rock up and back. And you can do that with the feet apart, the feet together, with one hand on the table, 2 hands on the table, no hands on the table, to progress them. They did that quick stepping in different directions. That can also be done in a set of parallel bars. We had them reaching outside the base of support, so rocking from one side to the other, forward and backward. And those, what I called recovery steps. So that's recovering yourself if you start to fall. So it's your center of gravity in the middle, and then you're starting to tip in a particular direction and you shoot the foot out quickly to catch you behind, left, right, behind, in front, and so on. And I used to get people off one at a time to do this type of dynamic balance, where you can see that was the grapevine. It comes from old school aerobics. So people will be stepping, complicated stepping maneuvers, so that they can try and improve their ability to move their feet in strange directions. And I would sometimes stop them. I'd get them stepping forward and backward and so on. I like this little individual example. As I said, we use the card system, but you can see here that this particular participant had increased his or her, I can't recall now, resistance and his dosage by 255%. So being able to give people that type of evidence of their improvement was so uplifting, because a lot of these people are very old and very frail, and everything is about either maintaining or preventing them getting, preventing a flare up. It's not really about improvement and goal setting and moving ahead. So that was one of the really key important findings from this. You can see here I'm teaching, this is in a cognitively impaired unit, people with memory support issues. I'm teaching them to do some complicated out, in front, step in front. He's going, what? In front, there we go, out, together. This fellow with big feet in front, out, behind, 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 out, in front, out, behind. It's much more fun if you make it into something interesting. We were doing tandem standing. So I'm sorry the quality of the video is not as fancy as the other ones, because it was taken on the phones. But I'd have usually a therapy assistant. If I had 10 people in a group, I'd have therapy assistant running the group through those the resistance training equipment, and I didn't need to be there because they had an individual dosage, and I could, myself or the other physical therapist, could take people off to do the high challenge balance exercise. What became apparent as well is that we could set the program up and prescribe the person and train the therapy assistants, and then the physical therapist doesn't need to be there except to check in, for example, once a fortnight to upgrade the dosage. So in terms of cost effectiveness, you can have an individually prescribed scientific dose and trained therapy assistants, or even volunteers. And I don't know if that happens in the States. In Australia, sometimes we have volunteers come into the care homes, and if they have a special interest in this type of thing, then we were able to train them as well to run the classes. So I pointed out previously that balance exercises can be dull, and that was our main issue with adherence. People tended to love coming and using the gym equipment, and then they would find all sorts of reasons once they got bored with those balance exercises to say, I need to duck off now, and off they go without finishing that balance component. And so we had to start trying to think of ways that it would make people more interested. And so I'm an educator as well. I have physical therapy, occupational therapy, exercise physiology students coming through our centres. And I challenged them to come up with fun and creative ways to make the balance more interesting. And so making games out of it was something that we found really improved adherence. So people would then do their exercise, their resistance training program at their therapeutic individualised dose, and then they would stay if they had something fun to do, involving balance. So the little lady there on the right has a Nerf gun in her hand. She was a chair in front and a chair behind, and she has her feet in semi-tandem position. So one foot a little in front of the other, toes, feet really together. She has a target in front, and she's trying to improve her personal best, shooting at the target. She had actually just shot me, hence the cheeky grin when I was trying to take a photo of her. The fellow here on the top left was wheelchair bound when he started with us. That was predominantly due to an acute illness which had him bedbound for a few weeks. Then he became deconditioned, and he just didn't have the opportunity and the access to best practice exercise to get back on his feet. And so by doing this program, he became mobile again. His balance, he used to be a boxer when he was younger, so we would start this, obviously didn't have boxing mitts on to start with. We'd have when he first was doing this type of balance work, he'd have someone standing behind him, someone in front of him. He'd practice the boxing moves, but he could grab the rails if necessary, and he had a person on either side. But he had progressed to the point where he could actually do some sparring there. These are other examples of fun activities. You can see on the left, we introduced a little dancing. I can say that the balance attendance dramatically increased when you introduce a whole lot of 20-something-year-old male physiotherapy students, and so did the use of lipsticks and hairspray. But they attended very happily for these dancing type sessions. The top right shows some games, and we bought a football table. You can see the man there has actually stood himself up out of his electric wheelchair in order to assemble the football table, and then we purposely make them too high so that you need to stand up to play football. So we learnt a lot about this, about how to make balance more interesting, which leads us on to the games that we've now introduced into the Smart Balance. So her does have a Smart Balance system, and they've had that for some time, but we wanted to make the exercises that we'd included in the Sunbeam program more accessible and part of that circuit. And so the Sunbeam element we had that you saw on the original video I showed a little while ago was people standing with their feet together or in semi-tandem or in tandem. They can have their hands on the rails, one hand, no hands. And what they do with this, it shows that the red dot in the middle between the feet shows where their center is. And if it's moving one way or the other, it helps them to correct themselves. And it's a bit of a game because they get points for how long they've been able to stay in a particular position. And that is saved for them. So next time they can try to beat their personal best. The other exercise you saw them doing was reaching outside of their base of support, so reaching left or right. And so there is another game where you try to beat your personal best by rocking your weight onto one foot and then the other foot. And then for stepping in different directions, we have added in some cognitive challenge for people who can do it as well. Or if a person is cognitively impaired, you can stand with them and tell them where you want them to step. So their feet will be in the middle of that V, and you might say, let's put your right foot on the red spot, or your right foot over there if the person doesn't and can no longer follow colours. And so that becomes a game for them as well. Or the next level up is that we give them some cryptic clues. So something I can do in a pool, and the letters there spell swim, but they need to think of the letter and then tap their left foot to the back, their right foot to the back, then their right foot to the front, then their left foot to the front, and it will score them if they get it right. So it's trying to make people more motivated to do those exercises that were shown to improve in the Sunbeam research. I love to share the story of this fellow. We'll call him Ian. He had cerebral palsy, and I first met him at the age of 80 when he was bent over using a four-wheel walker with low handles and resting his elbows on it. And he would walk dragging his right foot, and he had back pain. He had short walking distance before he ran out of puff. But he had a really strong spirit. You know, 80-year-old people with cerebral palsy were rare to find. A lot of them didn't make it that long. And certainly he had a father who'd been a general practitioner or a medical practitioner. So he basically just said to him, we expect you to do your chores, we expect you to participate. And so he had that mindset through his life. So he was really keen on the idea of being able to improve his physical function, and his goals were to be able to walk further and to be able to get rid of his back pain. So we were able to prescribe in an exercise program based on those principles I've shared with you already, and also to get him into one of those, we call them a forearm support frame, which means you're standing high and you have like a gutter that you put your arms in, so it helps you to stand up tall. And we gave him the strength program, and he did the balance program. We had to do a bit more one-on-one work with him because of he had one side weakness from the cerebral palsy, to make sure he was safer with the balance. But he participated. He was the one who was there, the 8 a.m. class in a skilled nursing facility. The men liked to come. That was our men's group. He'd be there at 10 to 8 every day. And if I rocked up at 5 to 8, or our therapy assistants, right, he'd be saying, you know, you're late. And then he would get in there, and he participated every week without fail. When the trial finished, he wanted to continue, so he kept coming. At 85, he had a new set of goals. He recently celebrated his 90th birthday, and his family called. I live in a country area outside of Sydney. His family from Sydney called and said, we'd like to take our uncle on a cruise for his 90th birthday. Would you mind having a wheelchair that we could borrow to take on the cruise with us? And so I told him that's what they'd said, and he said, all right, well, let's take it. And so we had a little chuckle to ourselves. And what they didn't know about him was that in the 5 years since they'd seen him at his 85th birthday, he was now walking tall, minimal dragging of the leg, no more back pain because he wasn't bent in half, and strong enough to walk around without needing a wheelchair. But we lent them a little folding wheelchair, and I said to him after the cruise, how did you go with the wheelchair? And he said, great, I pushed some of them around in it. So just to move on, that we've been talking falls prevention and reablement. We now know that the World Health Organization in 2022, the guidelines are we should be doing targeted, therapeutically designed exercise, strength and balance exercise, resistance training, even for frailty. The guidelines now, level 1 research for pain management, group exercise therapies are recommended for patients with chronic pain. So pain is not a reason not to exercise, but it does need to be individually prescribed so it's not going to aggravate the painful areas. In fact, that we say when I'm teaching the students, motion is lotion. So rather than massaging a sore area, even if that helps, we should be working on moving it so that it starts to free up, or moving it within a pain-free range, that kind of thing. But obviously that's not a blanket prescription. It needs to be done using scientific principles and an understanding of the pathology under the pain. So we now her introduced me to this word WellSpan. So it's not lifespan, it's WellSpan. We want to be well for as long as possible, not just live as long as possible. So a person who's had lifelong exercise, in looking at their exercise or functional capacity, they're likely, you know, when you're children, you're on the improve, you get to sort of 20 or 30. By 40, certainly it starts to decline through the middle ages. And even with lifelong exercise, you won't be at your peak, but you're going to be well above the capacity of people who have not done lifelong exercise. What about if we just did exercise that we sort of initiate around the middle age here? You can improve for sure, and compared to sedentary aging, which is this red line. And it shows that eventually, if you're going to be sedentary throughout your lifespan, you can expect falls, osteoporosis, frailty. It's associated with dementias and other cognitive impairments, cardiac disease, cardiopulmonary disease. These are well-documented facts that sedentary behaviours are associated with these long-term diseases. So what about if you make a decision in your middle age to exercise over here? Then you can change that trajectory, or even in your older age. But what's the optimal dose? It's not just any exercise. It does depend what you want to target here. So cardiopulmonary and cardiac disease will require more walking than falls prevention will. But that's why we have exercise scientists now. So your physical therapists, your exercise professionals who understand disease will be able to prescribe a program to improve your WellSpan. So I'd like to acknowledge the University of Sydney, the Centre for Health Economic Research and Evaluation. We conducted an cost effectiveness analysis on this, in the University of Queensland, and her, as well as the residents and the staff of all of those villages you can see there, who really put themselves out there to try something that had not been proven and required a fair bit of input from themselves in their later life. I'm really appreciative of that. So in summary, we can say that falls prevention, restoration and reablement are all possible in long-term care and in frail people who live in the community if the correct dose of strength and balance are implemented. There is evidence of health benefits and cost effectiveness. The key principles of the program shared with you today can be scaled and used across, it is being used across a lot of the world. I have these programs, feedback from these programs being run in Europe and in Asia. And in our experience, making the Balance Fund does make the people want to attend more often. So this is actually a little video. I'm sorry it's dark and it's the quality of the sound is poor. So I'm just going to share. This fellow at 94 years of age wrote me this poem on completion of the exercise program. He says, "A man's not old when his hair turns grey. A man's not old when his teeth decay. But a man's fast reaching his long last sleep when his mind makes an appointment that his body can't keep." Just really appealed to me and summed up the sentiment of our people who participated in the exercise program. So thank you for listening. I have included 2 email addresses there. I'm very happy if you would like to contact me through my University of Sydney address. I only work for the university nowadays 1 day a week because my passion is out in the world with older people. And so the other days I work with older people in long-term and community-based care. So you can also contact me on that other email address. Thank you for listening. So I'm going to hand back to Carol now, who's going to talk through this information and let me know of any questions that you may have. Thanks, Carol.
Thank you so much, Dr. Hewitt. Great presentation. We really appreciate you. We've had good attendance and I don't see any questions, but now would be a great time if anybody does have a question to put that in the chat, the webinar chat down at the bottom. Looks like 2 message bubbles. And we have a raised hand. Go ahead and just type.
Even better. It's all right. Oh, can they not speak? Maybe their webinar's muted.
No, we have that kind of auto set to a mute.
Okay.
So type your questions. That would be great. And while we're waiting, in case someone wants to do that, you can also send your questions to Dr. Hewitt at her email address or here to her USA. And we're also happy to answer questions or get you in touch. We will be sending out this presentation to everyone that joined and also to those that signed up but couldn't make it. So you'll be getting a follow-up email. You'll also be getting a follow-up email in case you do want to hear any more about our equipment, of course. Then you can just, there's a link you can click and then we'll work with you individually. We thought that was better than doing that all together now at the end. So I don't see any questions, but fantastic presentation. Thank you so much, Dr. Hewitt, for your time. I know it's early in the morning for you. It's the end of the day for us. And I hope you enjoy the rest of your summer.
Thank you.
All right. Thank you again. Thank you, everyone, for joining.
Thank you. Bye-bye.